let me check, Doctor, if you can you hear me now?
Yes, doctor.
Okay, ودكتور ياسر. No, we can't hear you. I can't hear the if you are talking, we cannot hear you.
What about now?
Again.
Okay, can you hear me now?
Yes, yes,
okay.
I can hear you now.
Good.
Yes, correct.
Okay, يلا بسم الله الرحمن الرحيم. السلام عليكم everybody and good morning. So I think we can start now. Today we are going to have Dr. Asma. She's a first year NICU fellow and she's going to talk about apnea of prematurity. Dr. Asma.
Assalamu alaikum. Today I'm going to represent apnea of prematurity topic. My objectives is to talk about definition, pathogenesis, management, general respiratory support, and medication, and discharge planning. So the definition, apnea of prematurity, it is developmental disorder in preterm infant which occur as a direct consequence of immature respiratory control. So the apnea is a cessation of breath more than 20 seconds for a shorter respiratory pause, 5 to 10 seconds associated with desaturation and bradycardia in neonate less than 37 weeks. So the apnea of prematurity, in contrast to periodic breathing, which is defined as 3 respiratory pulses with more than 3 seconds in between for up to 20 seconds, periodic breathing is normal unless associated with bradycardia or cyanosis. So the types of apnea is either central, in which there is absence of respiratory effort, and of course the flow. Obstructive, there is respiratory effort, but ineffective, there is no airflow, and mixed. In apnea of prematurity, mostly central or mixed. So the apnea usually occur on all neonates less than 28 weeks and may continue beyond 38 weeks of corrected gestational age. Resolution is typically completed by around 44-week corrected gestational age. Now I'm going to talk about pathogenesis of apnea of prematurity, but first I will just go rapidly through the talking about the respiratory control in the human. Respiratory control, actually, it is we can divide it to chemical and non-chemical, which is lung stretch, muscle joint receptor, and chemical, it is either central chemoreceptor or peripheral. And we have also cortex control for respiratory effort or respiratory control. Cortex, it means that when we are we cough or we need to hold the breathing, then it will be higher center than the medulla or midbrain. So today we will concentrate about the chemical chemoreceptor or chemosensitivity. So we have the midbrain, which content of bones, and the medulla oblongata, in which there is respiratory center. So the central chemoreceptor, it will be sensitive to hydrogen ion, and the peripheral chemoreceptor, it will be mainly affected or sensitive to hypoxia, oxygen, then to CO2, and also the acidity in the blood. All this will go to respiratory center, which is in the dorsal group of the medulla, which is responsible for the inspiration, to start inspiration, and it will stimulate the center. There is some inhibitory pathway which is coming from the bone, which is pneumatic center in the bones. It will inhibit this inspiratory, and actually it will affect shorten the inspiratory, and it will increase respiratory rate. And apneustic center, it's also present in the bones, and it is responsible to stimulate the inspiratory center, and it's usually responsible for the gasping breathing. So all these things, it will stimulate the inspiratory center, and then it will lead to stimulation for the respiration. So this is another diagram. It is showing the bones respiratory center, pneumatic center, which is responsible for the inhibition to the apneustic, and it will lead to inhibition to the inspiration, and apneustic, which is lead to stimulation, respiration, and this is the responsible center for the gasping breathing. In the medulla, we have dorsal group of respiration. It is mainly for the inspiration. And we have this complex Potzinger, which is like a pacemaker for the respiration. So this is like refreshment for our knowledge about the respiratory control, to understand what is the pathogenesis and apnea of prematurity. So the respiratory drive, as we said before, it will be response to the arterial perturbation of carbon dioxide, oxygen, and arterial pH. And also it will be affected with the neural and chemical sensitivity. We will talk now about respiratory control in fetus, in utero. So the in utero, it is different story. The baby is living in environment which is hypoxic. So the fetal respiration is periodic. It is non-continuous breathing. And hypoxia inhibit the central drive in the fetus. There is biphasic response to hypoxia in the preterm. Initially tachypnea, which is triggered by chemoreceptor, then central apnea. Usually in the fetus, neurotransmitter inhibit respiratory drive, and there is altered response to CO2. So the transition from intermittent or periodic breathing, which is normal intrauterine, to the continuous breathing, which is post or neonatal breathing, is still not fully understood. So physiological immaturity of the preterm result in many changes, or it will result in first impaired in respiratory drive, which is impaired in chemosensitivity. So there is diminished response for the carbon dioxide in the preterm, such in case of increase there is hypercapnia, increase in CO2, it will lead to increased tidal volume, but no change in respiratory rate with prolonged expiration, which is mediated centrally by inhibitory neurotransmitter, which is adenosine and dopamine and GABA and prostaglandin also. This all lead to CO2 apnea. The other things, it's oxygen chemosensitivity. As we said, oxygen, it is affect the baroreceptor in the carotid body. It will not be central affection. So the postnatal hyperoxia diminish the peripheral chemosensitivity, and it will lead to prolonged apnea. Recurrent apnea plus decrease in the drive, respiratory drive due to immaturity, it will lead to further hypoxia. Which is lead to increase the chemosensitivity and lead to increased respiratory rate, wash CO2, then the CO2, when the CO2 will be low, it will lead to apnea. As we know, the CO2 is the main respiratory drive in the human. Then second thing is enhanced sensitivity to inhibitory neurotransmitter, dopamine, adenosine, GABA, and prostaglandin also. Third thing, failure to maintain airway patency. So there will be collapse due to immaturity, of course. There will be collapse due to poor hypopharyngeal muscle tone, nasal obstruction, laryngeal edema also. All of this lead to apnea of prematurity. So immaturity, it will lead to enhanced inhibitory reflex, diminished hypercarbonic response, and hypoxic depression also. Hypoxic ventilation depression, all this will lead to apnea. So what is the clinical presentation? Usually preterm baby less than 28, some sources less than 30 weeks lead to persistent, it will persist till the term corrected gestational age. Usually start in the first 3 days after birth. Episode of desaturation typically increased after second and third week. Resolve before 37 weeks of corrected gestational age for baby delivered more than 28 weeks. If the baby on mechanical ventilation, the baby may have apnea and he is on mechanical ventilation because this apnea centrally, as we said, so we will notice that the baby had desaturation and the bradycardia in spite he is on mechanical ventilation. There is differential diagnosis for the apnea. Of course, the apnea, we should differentiate it between apnea and if the mother, she received antepartum opiate, beta blocker, magnesium sulfate, hypoxemia, hypothermia, anemia, sepsis, NIC, metabolic hypoglycemia, or if there is upper airway obstruction, CNS like IVH, encephalopathy, seizures, or if the baby receiving opiate. Feed also will affect the baby and may lead to apnea if there is high rate of milk flow, ineffective coordination between sucking and swallowing and breathing. Introduction of oral feeding also, it will lead to apnea. And medication such as prostaglandin in case of in case of congenital heart disease. Now we'll talk about the management. So our goal to reduce apnea and associated hypoxia. Therapy need long duration, weeks, as respiratory control mature. So we have general measures, which is reduce the apnea of prematurity, like reduce factor that increase the apnea, as we said before, and provide a stable thermal environment, avoid neck over extension or over flexion, maintain nasal patency, avoid prolonged use of NGT or vigorous suction, avoid hypoxia by giving oxygen, nursing in prone position. And second thing, we should send the lab to search for underlying cause of apnea, especially if it is new onset apnea or it is increased in the severity. So we'll send CBC to look for anemia and maybe the baby required backed RBC, and to look for sepsis. So we'll send blood culture and CRB also. RBS to look for hypoglycemia, CBG to look for acidosis, metabolic, sepsis or NIC. And the brain ultrasound, of course, to look for IVH. Then we have respiratory support with non-invasive ventilation, like CPAP, high flow nasal cannula, or non-invasive in IBBV. Caffeine or thiopheline. If all this fails and the baby still have recurrent apnea, may need to intubate the baby. Now we will talk about the caffeine as the main or cornerstone for treatment of apnea of prematurity. Caffeine is preferred agent as it is long half-life, wider margin of safety, less side effect, less BDA ligation, reduced incidence of PPD, early extubation and less period of oxygen supplementation, mechanical ventilation or CPAP, long-term neurodevelopmental outcome. Indication of caffeine, we are giving caffeine prophylactic in all infants less than 30 weeks. Consider starting in infant between 30 to 34 weeks in case of apnea of prematurity, if the baby have apnea, prolonged apnea or recurrent apnea. Facilitate to early extubated 24 hours before extubation or within 6 hours in unplanned extubation. To wean off BBV or sometime after surgery. So what is the dose of caffeine? Loading dose and maintenance dose, it depends on the caffeine, if it is caffeine citrate or caffeine base. So the caffeine base is a half dose of caffeine citrate. Caffeine citrate loading dose is 20 milligram per kg, while base is 10 milligram per kg. Maintenance, usually starting after 24 hours from loading dose of caffeine, and as before, citrate is 5 to 10 milligram per kg. Usually, if the baby extreme preterm, you're starting with high dose of maintenance, 10 milligram per kg. And if it is caffeine based, it will be 2.5 to 5 milligram per kg. Then the timing of caffeine, when we should start caffeine. There is no agreed protocol on the optimum timing and dosage of caffeine therapy for preterm babies. The timing of caffeine administration is highly variable, ranging from first hours of life to several days after birth. The effects of caffeine administration shortly after birth are unknown and needed to be studied with randomized placebo-controlled trial. There are insufficient data to recommend immediate caffeine administration in delivery room to prevent BPD. So what is the mechanism of action of caffeine? It is competitive inhibitor of adenosine receptor, which is inhibitory neurotransmitter of respiratory drive. So it will increase response to high CO2, decrease hypoxic depression. So it will reverse central hypoxic depression of breathing. It will enhance force of diaphragmatic contraction. It will improve pharyngeal muscle tone. It will increase MAB and minute ventilation, reduce effect of hypoxia in preterm white matter. It also had anti-inflammatory effect, diuretic effect, and it will reduce the requirement of surgical BDA closure, of course. So this is same as we talk about caffeine, what is the effect and what is the long or short effect of caffeine. It's almost same as I said, but little bit in detail. So what is the side effect of caffeine? The first side effect is feeding intolerance. It will decrease intestinal blood flow velocity and reduce short-term weight gain. It will lead to tachycardia, irritability, increased metabolic demand. What about thiophyllene? We know the caffeine has longer half time, 65 to 100 hours. And caffeine is given once daily. Enteral absorption of caffeine is more reliable. Wide therapeutic index, less side effect, as we said before. High margin of safety, less need for monitoring. While thiophyllene has same rate of reduction of apnea of prematurity in first week, but thiophyllene can cause GERD, delay gastric empty. And of course, so when we will stop caffeine? Discontinue of caffeine at postmenstrual age 32 to 34 if there is no apnea episode requiring intervention for 5 days. The caffeine, it takes up to 7 days to be eliminated from the neonate. There are limited data suggested prolonged therapy beyond 35 weeks. Rarely need to restart it after stopping the caffeine. Time of discontinuation important to prevent delay in discharge. So if the baby free apnea, bradycardia, desaturation 5 to 7 days before discharge, this is discharging plan. And if he is, of course, off caffeine therapy for at least 5 days, it will be based on the nurse observation and documentation of apnea events. No evidence that home monitoring can help or prevent SIDS. Prior to discharge, the parent must be received training in CPR, and RSV infection, surgery, vaccination can increase risk of apnea. Infant with the BPD had delay maturation respiratory control, so maybe infant with BPD, they required longer time to be treated with caffeine. Thank you so much.
مرحبا, thank you, Dr. Asma. مرحبا.
أهلا وسهلا.
مرحبا دكتورة.
Thank you, Dr. Asma. I'm Dr. Amna Al-Zaabi in ICU at Fujera Hospital. One question and 2 comments. First, my question is, what's the indications and how many apnea you will tolerate before intubating the patients? So the question is, usually now the people is tolerating the apnea more comparing previously. So how many apnea per hour, or how many apnea in the last 6 hours or 12 hours you will tolerate before intubating the patients. This is one. The second thing is there is a huge trial, they call it CAP trial, and they follow up the patient up to 18 years. يعني ضلوا يعني خذوا مجموعة and they keep following them for long, and a huge study يعني فيها كثير من it was randomized, and most of the indication and contraindication coming from CAP trials. فكنت أتمنى إن نحن نسمع شيء عن الCAP trials, especially they have good follow-up after 18 years of follow-up of their patients. Thank you.
Yes, doctor. Thank you so much for this question. For CAP trial, yeah, I read it actually, and it is long, as you said. It is a long study, and it have many study regarding the short-term effect of caffeine and long-term affection of caffeine with most neurodevelopmental up to 18 years, as you said. Actually, I prepared this presentation in short period, and this CAP study, it will require maybe separate presentation if I want to talk about it, because it is too much long. Regarding the first question, actually, I have decided to intubate the
Thank you, Dr.
The sound is not clear.
Yes, can you hear me now, Dr. Amna?
Yes, Dr.
Amna?
Yes, I can hear you now.
Okay, so regarding the CAP trial, I don't think they reached the 18 years yet. Like when I was a fellow in 2013, they just published the 5 years. So I don't think I'm old enough to catch up the 18 years follow-up. I worked with one of the authors, Dr. Diane Modiman, and yes, I agree. It's very informative, very long. There are many studies that came out of this study, but the main thing they focused on the neurodevelopment. At 36 months, they found a good neurodevelopment outcome in probably all the aspects of the Bailey assessment. On 5 years, they did not find that much significant in the fine motor. So that's, as far as I know, the latest thing that they happened. Probably now they published the 10 years. I don't think they reached the 18 years outcome yet. Regarding the indication of intubation, this is a $1 million question, Dr. Amna. I don't think anybody can answer this question anywhere in the world. However, if you review the NIP-V trial, you will find probably the things that we used mostly, that if you have more than 6 events, when I mean events, either apnea and or bradycardia and or desaturation, if you have more than 6 within the last 6 hours that needed only stimulation or oxygen therapy, or you had more than 2 in the last 6 hours that needed PPV, this is probably indication of reintubation. However, this is just a rough guideline, and we usually go beyond and after. And I think that the best thing to do, and what I like, one of the things I most like with Dr. Asma presentation, is the documentation of apnea that unfortunately we don't have. Because with the documentation of apnea, you will see day by day how bad we are and what is the trend. And the trend is very important. Like we usually say, the trend is your friend. So always we should look at the trend, not only in the apnea and everything, like the CO2, the PO2, the FiO2. We should look for the trend and see. If I see, for example, in the last 12 hours, the baby had only 2 apneas, and then within the next 6 hours, the baby is having 4 or 5, this will highlight a lot of alerts for me. So probably these are just a rough guidelines to guide you through these apneas, but I don't think there is an exact way to know when these babies should be reintubated.
So this is what exactly we are doing here. We are tolerating 2 with bag mask ventilations, not maximum than that. And we tolerate more the self-limiting or the one that need just gentle stimulation, as you mentioned, 4 to 6 apnea. before we put the tube in. And طبعا we upgrade him. If he's in CPAP, we put him on NIF-PC to help him more. Thank you, Doctor.
Okay, thank you, Dr. Amna. Any questions? Any more
yes,
questions?
Yes, Doctor, I have a question.
Yes, go ahead, please.
I'm Dr. Hanan. I am an ICU fellow year 1 in Al-Qasimi Children's Maternity Hospital. Just because I had experience in Fujairah Hospital, and there is just some question, I don't know, maybe evidence-based or some study behind that. What is the role of the apnea monitor? We know it's like a proactive measure to detect an early apnea, because we cannot depend 100% on the nursing observation and the conventional monitor, because sometimes we have something what is called alarm dependence or alarm tolerance, and the nurses get to off in the normal conventional monitor. But is the use of the separate apnea monitor have a role, or it have, let's say, an outcome, or that's I'm just like a questioning if there is some great benefit in detecting the prolonged and the deep apnea. Is it not just like a short term for a few seconds to label it as an apnea? Because I feel that will be beneficial. So what is your comment, Doctor, regarding this thing?
Yes, Dr. Arula.
I think, I got your question. To monitor for apnea, I got your question that you mean to have a tool that detects the apnea itself, to record how many apnea events we got, let's say, in the last 6 hours or in the last 24 hours. That was your question, isn't it?
It should be like we have a separate apnea monitor, not like within the normal conventional monitor.
It is within the normal conventional monitor. We do not have a separate apnea monitor, but I think if, as we have said initially, Dr. Yasser has mentioned, the trend is your friend. When we go back with the, let's say, the histogram, I think it can tell us what is the number of the, what is the percentage of the getting the, let's say, histogram for the saturation, or histogram for the pulse to tell us about the bradycardia. And with that, we can go back with the sister to check exactly why was the baby getting desaturation around this number, while yesterday or the day before, the desaturation or the number of the percentage of the desaturation was less. I think we can do it, but this is again a conventional way. It is not objective. It is the subjective and the different from one individual to individual. But there is in the market, there is the apnea monitors. I know that there are apnea monitors, but we do not have one here in the unit as Hanan.
Yes, Dr. Hanan, I don't have that much experience with apnea monitors. I can see them like, I think we use them in Amran Hospital. I don't have enough background to answer this question, but I would like to invite one of Amran Hospital, probably Dr. Khalid, if you have enough experience or if you know about any evidence behind this apnea monitors that we've been using for some time now. Dr. Khalid?
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
This is Dr. Muhammad Hamid from Fujairah Hospital and ICU. So just one question. Apnea is a broad, it is a symptom that it is unspecific, so especially for preterm babies. So how I can differentiate in a preterm baby, this apnea is due to its prematurity, and it's not due to other possible causes like infection and other causes. Is it anything that can guide me to know more? Is it apnea other than prematurity?
Yeah, Doctor, regarding your question, already we talked about it in the lecture regarding the differential diagnosis of apnea. If my sound is clear, yeah? Okay. If the baby just delivered in the first 3 days and he have apnea and he is extreme preterm, of course we start to manage the baby as apnea of prematurity, and we start to give the baby caffeine and respiratory support. But if the baby had frequent recurrent apnea and he's not responding, we should research for other causes. If the baby had recurrent apnea, new onset of apnea, increasing the frequency of apnea, so at that time you will send CBC to look for anemia, to send for sepsis workup, as the sepsis is the major cause of apnea in neonate, and you will request brain ultrasound to look for IVS and to look for the history. If the mother, she is receiving opiate and the baby just delivered and he had apnea, there is many differential diagnosis for apnea. We should work for it. You should send CBG to see what is the issue with the baby. How's the baby acidotic? He's have lactic acidosis. And according to that, you will work. But of course, if the baby from the beginning, in the first 3 days, and he is extreme preterm, we will let our first differential diagnosis apnea of prematurity.
So the onset of apnea, is it important? The onset of apnea, if it appears in the first day of life or 7 days later?
Onset of apnea of prematurity, you mean? Apnea of prematurity, it is usually present in the first 3 days, but may late for 1 week. It may be after 3 days. From 3 days to for the first week of the life of the preterm baby can be presented, and we can nominate it as apnea of prematurity.
Okay, we have a comment and a question from Dr. Khalid. First question, is there a specific time of the day is preferred for administration? I think he means caffeine. Also, do we need to do level in selected cases?
So regarding the first question, timing of caffeine, also we talk about it in the presentation. The timing is till now there is no approved or regarding the time of starting caffeine. Some they are starting in the labor room, some they are starting within the first 3 days, some they are starting after 3 days. But of course, the starting caffeine as early as possible is the best for the baby. You want to add something?
Yes, I wanted to add something like a comment here. I used in the practice in my previous workplace, as the caffeine is known with its role to enhance the catecholamine release. Even if, let's say, the baby was born at middle of the day or at night, the first caffeine was given. We will gradually prepone, give it like 2-3 hours earlier, the next day, till we reach to a period to administer the caffeine early in the morning, between like 4 to 6 a.m. in the morning. Most of our babies, or the idea was to give the caffeine for 4 to 6 a.m. in the morning is the time to administer caffeine to all the babies in the unit. Whatever the first dose of caffeine was given within the day, we will just prepone it the next day to be given within this period, linking that to the effect of the caffeine to enhance the release of the catecholamine, and the surge of the catecholamine is given in the body around that time of the day. But صراحة, I came across one article that talks about that. When Asma asked me to get this article to her, I was looking again, I couldn't find it. Actually, I don't know where I have saved it. But it is really interesting.
But theoretically, it can be done, as the caffeine is...
Also, Dr. Khalid is commenting for the sake of giving, I think he's talking about taking the level for the sake of giving higher doses in selected cases with frequent cardiorespiratory events. I'm not sure if there is any study that's been done to follow the caffeine level, but as far as I remember, we had 1 or 2 cases we reached very high, relatively very high dose of like up till 16 milligram per kg per day. And at that time, we wanted to know how safe we are giving these high doses, provided there is no evidence for that. And we got a caffeine level at this time. So I don't think there is a study, but sure, you can do that for selected cases if you feel that you need higher than the recommended dose of caffeine, just to be sure. Regarding the time of administration, I don't think there is a wrong or right way of doing it. Some people, what I would do is giving what we call an extra mini load dose on the top of the dose that we used to give. Like if the baby is taking the dose at 6 a.m. and by 12 p.m. the baby starts to have recurrent apneas, I will give it a shot and give him an extra 5 milligram per kg of caffeine-based dose, or 10 milligram per kg of caffeine straight, and see if this is going to help, provided the baby is not having tachycardia or feeding issues. The other way of going around this is to split the dose into Q12 hours, especially in chronic lung disease babies, and also just by personal experience. This is very humble experience I have, and it worked out for many babies. Like if you give the dose at 6 a.m. in the morning and the baby on a daily basis starts to have frequent apneas in the evening, so what I would do, I would split the dose into Q12 hours instead of Q24 hours, and I feel it works most of the time. So I don't think there's a harm of trying this to save the babies this after midnight frequent apneas. I'm not sure if there is any comment regarding these two important points from the other audience.
Interesting.
Any more comments from any of the colleagues? Unfortunately, Dr. Khalid cannot join us. Some issues with the mic, but if there is no more comments or questions, I think we can conclude now. Yes, thank you very much, everybody. It was a very nice presentation and very nice discussion. Thanks for all the audience and attendees. Have a wonderful day. Thank you.
Thank you.